Good morning, everyone. We shall start the conference proper right now. Warmest welcome to all our participants, especially those coming from afar. Welcome to Hong Kong. We've got beautiful weather today, and I hope it keeps. We had quite a bit of mist for the past few evenings, but well, today looks promising. But with this, thank you so much for joining us for this meeting. I'm delighted to be joined by Dr. Zohar Lederman. So this meeting is held in collaboration between the Center for Medical Ethics and Law, which is jointly run by the School of Law and the School of Medicine, or faculty, as we call it here, together with the Medical Ethics and Humanities unit of the medical school, which is represented by Dr. Lederman. So I'd like to start off by firstly thanking, of course, everyone here and also our very generous supporter, the Wing Foundation. So it is because of their generous grant to the center that has enabled us to organize this event and also a meeting earlier in the week. So my apologies in advance for the tardiness. It's been quite a busy week for us. The reason is because we are taking the opportunity to have these activities mark our 10th anniversary, the 10th year since the founding of the center. Well, 10th thereabout. I mean, we can debate how we can count the start date, but we generally take it as the 10th year this year. So I'm also immensely grateful to my colleagues, Miss Jane O, and Miss Candy Ip. So Candy is there. Many of you from overseas would know Candy. It's really for excellent work that's getting all of these things together, these activities. So so my grateful thanks to colleagues there. Well, this meeting follows on from a number of AMR related work that myself and colleagues have been involved in. Most recently, well, it's linked to a Just Transition project. It's known as Just Transition, it's funded by the British Academy, thinking about some of the changes in relation to AMR that may be anticipated. There are the very broad changes. Of course, this we can immediately think of as climate change at that sort of macro level. And then there are the more micro level changes, such as institutional practice that have been going on for a long time in response to AMR related concerns. So this particular meeting is going to have a wide focus in the sense that it addresses all of these levels, macro, meso, and micro, because as I think many in the audience will agree, that you see these developments across all of these various scales. So before I start the session proper, I just wanted to mention, and you may have already seen this in the invites that have gone around, that there is a simultaneous translation feature. So if you have your devices with you and if you are to log into Zoom, you will be able to see the simultaneous translation feature. So for those of our colleagues who were with us in the earlier meeting, it is not going to be the headsets, although if you log into Zoom, you'll be able to see the translation. I mentioned this because some of our colleagues will be presenting or maybe presenting in Mandarin, so it will be helpful to have the aid of your device. So with this, let me start with a very brief introduction of the meeting itself. Sorry, I did forget that Dr. Lederman may have a few words to add. Dr. Lederman?
Well, hello, everybody. Good morning. Not a lot to add, just that I'm happy to see you all, old friends and some new friends. And I'm excited for the conference and to learn more about Digital One Health. I'm just sad to acknowledge that Calvin will be leaving us. So it's unfortunate that I won't have any other people to organize this kind of events with. So that's unfortunate. But thank you, Calvin.
Thank you, Zohar. Very kind of you to say, well, at least there's someone less to harass you in terms of all these activities. But that said, There was to be continuing collaborations, and I very much look forward to that, including this one. So this topic sits in between two of the four key flagship research areas of the center. So one relating to emerging technologies, that's the digitalization aspect, and the other area being public health law or global health, depending on how you defined it. So this particular discussion will sit in the intersection between these two areas. Our two other key research area will pertain to clinical ethics and health law. That's where you'd find Dr. Lederman very active in this space as well. And then mental health and disability. That's the fourth research area that the center focuses on. So concerning the meeting itself, I guess everybody would have seen this in the write-up. We have the broad theme of looking at, in fact, two broad developments. So one pertaining to One Health, and then, of course, drawing in the digitalization aspect. So depending on, and this is a debate that I think we will have, depending on how you look at this particular development, some have called it Digital One Health, others have called it One Digital Health. So there would be a lot of course, politics linked to it, and of concern to us, of course, will be the governance aspect. But because there are so many values that relate to these sorts of developments, we want to focus, for the purposes of this meeting, on justice, and more specifically, data justice, because justice is a hugely complex concept. As many of you in the audience will know. And so we thought we'll start off by looking at data justice, a concept that's been put forward by Lynette Taylor. So this is one, it's not the only concept, clearly, but I think a good starting point to help us think about some of the issues. I think it did provoke a response, which you'll hear shortly from Dr. Lederman. The framework that Lynette has put forward is anthropocentric, admittedly, but I think that that's a good starting point, because we want to think about whether this framework could be helpful in drawing in the other realms, the other dimensions. So namely in the plant domain, plant and animals. And then beyond that, of course, we're talking about earth science and a lot of data that's coming out of that particular area and research in particular. So we hope that looking at this broad phenomenon, there would be sub-themes that we could perhaps probe into, perhaps over the course of today and a bit tomorrow. But my hope is that this will be a continuing conversation. So perhaps in different places. So even if I am to be in a different place, these are the sort of conversations I think we should continue to have. So what are these sub-themes exactly? I think that we might want to probe into different conceptions of data justice in international law and global health law. We're joined by a number of scholars who have done a lot of work in this place. I'd like to acknowledge in particular our colleague here, Dr. Claire Lajournay, because she has helped me to think in the past a lot about these developments, and very keen to hear your thoughts moving forward. So that's one particular sub-theme that I hope we'll get to think about, particularly in light of more recent developments on the access and benefit sharing scheme under the Convention on Biological Diversity. And then there are barriers that we could consider, barriers to effective use of digital tools. Some of our colleagues will be speaking to this. I'd like to highlight in particular what Dr. Rohit Malpani would speak to us about. So that's tomorrow, actually. We do have a segment that's devoted to big data and to AI. So that I'm hoping that we'll have conversations on this particular theme in particular there. That said, there's a slight change to our program. Our colleague, Dr. Ping, has got commitments back across the border in Shenzhen. So while she was scheduled to present tomorrow, we need to move her forward in order to have the benefit of hearing her. So she's going to introduce to us the ethical framework that's been developed. In fact, on mainland China, you see very sophisticated regimes emerging in response to a number of these digitalization initiatives, including the use of big data analytics and AI. So Dr. Ziping will speak to us after we've heard from Mike. So Dr. Mike King, well, he's going to introduce us to, or help us rethink about, or think deeper about the One Health notion and the sort of ethical imperatives that will come from there. So many thanks in advance to Mike. So after Dr. Mike King has spoken, Ziping will share with us the research ethics framework that has emerged on mainland China. And then we'll hear from Dr. Lederman. Sorry about the change there. So slight adjustment, but then as you see, all of these discussions will have a very clear policy focus. So while part of the discourse that's going on would be essentially academic or discourses, depending on how we define this, that we hope that there will be practical outputs in terms of policy development. So all of these discussions are also meant to, at various levels, support policy development here in Hong Kong and elsewhere in the world. So very quickly, for those who are not familiar with One Health, I thought this might be helpful to say that antimicrobial resistance is not the only focus of One Health. So One Health has got a much wider remit. But if we think about the definition of One Health that's been put forward, you see at the last bullet point there that it speaks to an integrated, unifying approach that aims to sustainably balance and optimize the health of people, animals, and ecosystems. It's a great initiative, but how well we're doing is open to question in drawing all of these different areas together. Of course, the approach itself also hopes to mobilize multiple sectors, as we see the very last bullet point on the slide. We'll hear shortly today from Dr. Isaac Weldon, who will speak to a lot of the collective action problems that we continue to face. So how to surmount some of these collective action problems is hopefully another theme that we would take on. We have seen in terms of our time in responding to the COVID-19 pandemic, a lot of these problems that are as yet unresolved. Hopefully there'll be some opportunity to talk about the pandemic accord that's being negotiated by the international negotiation body, and of course hosted by the World Health Organization. Progress has been very slow, but there has been some progress. Our hope is that the discussions here could also contribute to that particular development in collaboration with our World Health Organization colleagues. So an additional sort of sub-objective, hopefully, that will come from this meeting. So graphically, that's what you'd have in terms of the One Health dynamics. But I thought that it may be helpful to just put this out, because when we talk about the informational domain or the data domain, it links up with these three sources, again, broadly speaking, and then, of course, the intersection among these various domains. There is a global action plan put forward. That is something that we would speak more about. Claire may be speaking a bit about that. And then, of course, to help us think about what we need to do in moving the agenda forward, particularly in response to AMR. So when we think about AMR, I'm not sure whether there'll be an opportunity to delve deeper into this. Perhaps Sash, Dr. Sash Morone may speak to this. When we think about animals and we think about non-human entities, it remains a difficult question as to whether some sort of moral status could be attributed to them. So Dr. Lederman might also speak to that. And it's even more difficult when we think about whether they should have any kind of legal standing. So, of course, famously, there's been some work around whether trees should have standing. So if we were to extend that proposition, one could also consider whether at some point microbes should have some kind of legal standing. It's quite controversial, but of course, our New Zealand colleagues will tell us that it's not too far-fetched because rivers have legal status. Some river, at least, have legal status in New Zealand. So it is perhaps one development that could be helpful in thinking about this space. I suppose the other way that we could also engage with a number of these problems is to consider the different levers that could be applied. I'm not sure how much we are able to go into some of the other levers apart from regulatory ones or the more normative ones, but just to put it out there, these are a number of levers that we could consider. Some of our colleagues have put out arguments for digital rights. Of course, again, this is extremely anthropocentric in focus, but here you'd find that that's in part the limitation if we are to adopt frameworks such as this rights-based framework essentially into the One Health space. So it speaks to human-related concerns, but not so much, I would think, where we're concerned with plants, animals, or non-human entities. So that would be, therefore, a reason, I think, to look more broadly in thinking about what justice could mean and the way that would point us to. So, looking into some of the points that Lynette has very helpfully set out. Again, just to clarify, the framework that she put up is essentially anthropocentric. So we do need to think more about if we are to extend this to non-human entities, to think about how such a framework could be extended, if at all. So, but within the human domain, she has highlighted that there are challenges when we render certain things visible or invisible. So those who were with us in the earlier conference, you know that this has got exclusionary effects as well. And of course, that could exacerbate justice-related concerns or injustices. So, but what I find interesting about Lynette's framework is its foundation in capabilities. So, so the capabilities approach developed by Amartya Sen and Martha Nussbaum being the key movers. So, drawing on that broad concept, Lynette has argued that we perhaps could think about a number of questions linked up with the whole notion of rendering certain things visible, and perhaps in contrast, making other things less visible or invisible in the dynamics of engaging with technology. And of course, then this whole notion of discrimination that could come from rendering certain things visible or invisible. And these are, I thought, a number of helpful questions that we could perhaps think about. There will be some discussions, of course, on the last point in particular pertaining to surveillance and the impact of big data analytics in this development. So finally, if we try to pull together capabilities or capabilities approach and data science, what Lynette has very helpfully done would be to set out a number of areas that we might want to consider, thinking about the social impact of datafication, implications on data justice, its impact on functionings as understood within a capabilities framework, and then of course finally impacting capabilities in terms of opportunities and opportunity sets of individuals to live well. So whether we can draw all of these things together within the human domain is one of the critical questions in ways that would be consistent with the goals of justice, and to pull in other domains, particularly non-human dimensions or sources. That's hopefully one of the key questions that we can address. So with this, that's the broad introduction. I do wonder if anyone has any questions or comments at this stage, whether it's about what we have considered so far or more generally in relation to the conference. All good, Dr. Lederman? Okay, thank you very much. So with this, we will move to our first presentation. I'm delighted to welcome Dr. Mike King. So he's going to share with us about the social license aspect of One Digital Health. So Dr. Mike King's, of course, his CV is set out in the program. You're welcome to have a look at that.
Thanks very much, Kelvin, and thank you very much to the Centre for Medical Ethics and Law and the Medical Ethics and Humanities Unit for bringing me over here. It's wonderful to be here, and congratulations on your 10th anniversary. And it's wonderful to be here with my colleague, Nick, who will be speaking tomorrow, I think, and I'll be saying a little bit about her work. We work together on a project that is related to antimicrobial development, research and development. And so I just have a little disclosure at the start here about this research. So this work is funded by the Ministry of Business, Innovation and Employment, which is a large funding arm of the government in New Zealand. And they fund research because it's economically valuable, and well, they think it will be. And so this project aims to develop antimicrobials for use solely in animals. They're novel antimicrobials, and the aim is to keep them just for animal use. Obviously, this raises ethical questions. We're on the project to try and explore those questions and come up with better questions and hopefully some answers if we can. Nick and I don't make any money out of it. We don't have any financial stake in this, but it's just to say that. So now we know, and Kelvin has already said, about the massive antimicrobial resistance crisis that we're dealing with at the moment, and that's just going to increase. It's in the World Health Organization's top 10 global public health threats. About 1.3 million people die every year from antimicrobial resistant infections. That's projected to increase to around about 10 million per year over the next sort of 25 years or so. So it's a big, bad problem. Solutions for it are really important and need to be prioritized. One of the big drivers for antimicrobial resistance is international travel. Antimicrobial resistance links up the world, and it's linked up by travel, and it's linked up by the infections that are transmitted by people encountering other people, and also mediated by the environment. So that brings the environment in, also brings in animals in an interesting way. This slide here shows factors that contribute to the development of antimicrobial resistance. And it has, you can see here we have the contribution from low to high of these factors and the evidence for those factors according to Holmes et al. So what we have here in the high evidence and high contribution area is human antimicrobial misuse or overuse and animal antimicrobial misuse or overuse. We know that antimicrobials are used inappropriately in people a lot, particularly in New Zealand, that happens. Although it's interesting how that cashes out across different demographics and groups in society. Māori in New Zealand, our Indigenous population, are undertreated with antimicrobials relative to their disease burden. So merely reducing antimicrobial use introduces interesting sort of justice problems there. And also we have a lot of misuse of antimicrobials in animals. Now, a lot of that is misuse through using them as growth promoters, but it is also using them to mask environmental problems to do with the conditions in which animals are farmed, where they're surrounded by a lot of pathogens. And there's a link between, or there's presumed to be a link between human and animal use of antimicrobials. And there's a lot of sort of different explanations for how that link can be borne out. But that raises the fact that we're using antimicrobials, the same antimicrobials currently in both humans and animals. And that means that when resistance develops to one antimicrobial in one species, then there's the potential for that to affect the other species. So that arises because of the link between humans and animals, which is obviously a One Health problem, and also because of the link that we have in our prescribing practices for both, or the use practices for both humans and animals. So the idea with this project that we think is quite interesting is to break that link in the use of antimicrobials between humans and animals. Raises a lot of ethical questions, and I'm happy to talk more about those outside of this talk. I'm not really going to get too much into those, but I'm happy to talk about them, and Nick will speak a little bit more about those things tomorrow, and we're obviously around to have a chat. We're very interested in your thoughts about this. But the idea in this project is to develop novel classes of antimicrobials for sole use in animals. So if resistance develops within animals, to those antimicrobials, that won't be a resistance that is a threat for the use of antimicrobials in people. That seems like animals win because they get an antimicrobial that they can benefit from in a health way, ideally. And people win because it helps to reduce the development of antimicrobial resistance for their classes that they use. So that's the project. I won't say too much more about it. And in fact, much of the talk after this, I'll touch a little bit on it, but the rest of the talk is mostly sort of getting a little bit broader now about trust and how we see trust playing out in this project and what that means for One Health more broadly and One Digital Health as well. So Nick Liebergreen is talking tomorrow, oh no, not tomorrow, this afternoon, about the different barriers that we've discovered in an empirical side to our research. This is talking to people who are involved in the use or regulation of use of antimicrobials in different ways. But one barrier that or sort of broad class of barriers that we've encountered is to do with trust. So the proposal that we're looking at, which is to reserve some antimicrobials for sole use in animals, relies on effective regulation. So it relies on people obeying that prescription, right? That prescription being use it only in animals, don't use it in people. And this would go along with effective stewardship, and that's obviously that requires a lot of regulation of people's actions as well. And also, ideally, it would require a lot of surveillance of this use and surveillance of antimicrobial resistance development as well. So there's a lot of compliance and trust that's needed for that compliance to occur, right? Compliance with surveillance, compliance with changing practices, and all of that requires trust in order to be effective, right? And that's trust between all sorts of stakeholders here. I've listed some of them, but there's many more than I could put on the slide here. So vets and clients, regarding animals, clients and their animals, among vets, you know, different prescribing practices and so on. And trusting that, you know, so we're going to hear about collective action problems, which is terrific. All sorts of collective action problems can arise, partly out of not trusting that other people are going to follow a rule as well. Also, between human clinicians and vets is a One Health problem. And so you have sort of trust needed across the health sector so that people can move in a coordinated and regulated way. And also between regulators and these different sectors as well. And that is at from the very local levels through to the broadest possible levels as well, when we talk about that One Health sort of global problem. I also mentioned cultural groupings being significant here, and there's also socio-demographic groupings. And you get all sorts of differences amongst these groups in terms of how people are affected by different policy proposals and different prescribing practices and so on. And there are different needs, different moral orientations and so on. And this invites all sorts of problems for trust. Trust is a key component of social license. So I don't know if you've heard of this guy. This is Jim Cooney. He was in 1997 the director of the Canadian mining company called Placer Dome. He won in, I think, 2011 or 2013 the Canadian Institute of Mining Sustainability Award, which I found quite amusing. It seems a little bit like winning the Donald Trump Award for tact and diplomacy or something, something like that. But he is a thoughtful guy with a background in politics and philosophy. And he recognized that mining faced problems, not just that were beyond the political problems that they faced when they set about, you know, mining in different countries. You'd get a government permit, right? So that's one challenge. If you're going to do this, get a government permit. But they found that there were broader socio-political problems that they encountered to do with the communities in which they were conducting their activities. So he recognized that two tracks needed to be explored for their work to be effective. That was that you needed to have a positive relationship with the local people who were being directly affected by your work, right? So he coined the term social license for the development of this positive relationship with people directly affected by any policy proposal or any action like this. I got to say, social license is often not well regarded as a concept. It's associated with extractive industries. I think it's a very interesting concept. It comes up in all sorts of areas. I do some work in animal use and research. Social license is talked about a lot in animal use and research. People don't think it's a problem at all. They think it's a great concept. They think they're doing the right thing by doing it. But there's, actually in my next slide, I'll get into some of the problems with it. But what social license is basically a sort of a progression of a relationship from rejection of the activity that you're proposing to do in some area with stakeholders or people affected by it, people who have a stake in it. They could reject that. They might think it's an illegitimate thing for you to do. We don't like it. We don't want it happening here. So that's the withholding of their sort of license in this sense, right? Their sort of permission. They regard it as an illegitimate activity. If they regard it as legitimate, they might tolerate it. They think it's something that they disapprove of, but will let you go about doing it, right? We're not going to support it. So they accept it. Tolerance is acceptance of something that you disapprove of, right? If you regard it as credible, then you approve of it, right? So you approve of the activity going on, you approve of the people doing it, and you start to support it in different ways, or beyond mere tolerance. And this is sort of a one of the many kinds of ways of sort of conceptions of social license. You progress beyond that approval. If you gain trust, then they say there will be psychological identification, right? This is when the people identify psychologically with the activity. They sort of feel a part of it. They feel like what's at stake in the activity is something that they have an active positive stake in, right? All of this can seem quite creepy, I think, psychological identification of an extractive mining industry or something like that. I think a lot of people find this quite a creepy concept that a corporation is going to persuade you to identify with it, like Elon Musk might want you to do with X now or something like that, So it's criticized because there's all sorts of different ways of getting people to trust you. And you might not be trustworthy. So you can bamboozle people, you can tell them all sorts of things, you can just manipulate them in different ways by being appealing or funny or likable or something like that. You're not actually a trustworthy person. So social license, if we look merely at the trust side of it, the permission side of it, the actual licensing of society or whatever social grouping is, it's just to describe an attitude, right? An attitude of permission or a stance of permission toward an activity. It doesn't mean that the activity has normatively valuable components. Right? So we can think of social license as having two components, a sort of a descriptive component where the people do in fact give their permission or their trust, and whether the activity ought to be permitted or ought to be accepted, ought to be trusted, or those in it ought to be trusted. So Tim Dare, who's a good philosopher from the University of Auckland, has written a good article that I cited there, Normativity of Social License, where he really lays into the concept, right? It's basically not a particularly good concept because it doesn't have a strong moral component to it. So for the purposes of the rest of this talk, I think I will treat it as a thick concept, a concept that has descriptive component and a normative component. I think that's fine, or at least I think at the moment it's fine. We'll see where we end up or where I end up after this from having spoken to you. So if we treat it like that, in order to have social license, it's important for an activity to be trustworthy as well as trusted, right? Accepted because it is acceptable, morally acceptable, what's going on, right? Then the thick concept is satisfied in both its descriptive and its normative senses. So if we sort of have that rough idea in mind, and there's much more to say about what the normative component is there, right? And at this point, I'll just leave that open. I think Lynette Taylor's data justice, perfectly fine. It's something you could put in as the normative element, or there's all sorts of other things that could go in there, but I'll just leave it as a sort of a formal statement of the concept at this point. So here's just a picture I grabbed of One Health that just shows how big it is as a subject and topic, right? Or this is just in terms of its focuses, right? Let alone all of the many disciplines, different sources of knowledge that are needed to make it work, right? So obviously it ties in human, animal health and the environment. And if we look just at antimicrobial resistance, you've got pathogen detection, identification, you've got various public health measures to sanitation, getting people healthy, let alone, appropriately using antimicrobials to treat disease when it arises and comorbidities and so on. You also have surveillance. That's important. Surveillance is a massive obstacle, I think, for addressing antimicrobial resistance. All of the different sectors involved here can be affected in all sorts of different ways by any proposal that you think of in One Health. You get, at the level of every individual, let alone the different groups, trade-offs that they'll each be making or facing. And these trade-offs will differ across groups and across individuals. And those groups will intersectional. You'll have overlapping groups. You might be part of a socio-demographic group as well as part of a center and part of a cultural group and so on. Part of a grouping as a country or state. So getting some sort of agreement in those cases in the face of all of these trade-offs is very complicated to do. There's collective action problems that I've mentioned, and there's the risk of moral hazard because of this complexity, which is a very normal thing. It's just that when we think about One Health overall, there's an enormous number of these sorts of things to try and deal with. So if we think of social license as something that One Health needs, then this poses potentially a lot of problems for it. Trying to negotiate a lot of trade-offs so that people might think that what is being proposed, we should adopt a One Health approach to policy or something, is something that they ought to agree to, right? That they want to agree to because it's agreeable to them. They think because it's acceptable. You also have vulnerable moral subjects here, and I'll just assert basically that the environment is a moral subject here, a moral patient. And that animals are as well, even though when we look at a lot of the moral components that would go into social license, there's often work to be done to extend those to animals and the environment. That's certainly the case for the capabilities approach, data justice as well, and so on. If you look at all of the different actors involved here and all of the different stakeholders, there's a lot of variable moral orientations, right? People can have different reasonable conceptions of the good, and they will have different moral commitments. These will cash out in all sorts of different ways for them, and conflicting interests. So in trying to come up with any policy proposal that satisfies the sort of thick aspects of moral license, it's going to be very difficult to try and meet people in terms of what they want to see morally from their perspective. There's trust lacking between many stakeholders in One Health, and Nick will talk a lot more about some different examples of that in her talk. So that means that achieving social license for One Health in general, let alone any particular One Health initiative, is always going to be a challenge. It's a big challenge. And One Health in general might, the sort of social license for that, the sort of trust for that might actually arise in the aggregate of multiple overlapping sort of licenses for different proposals. If we look at One Digital Health, then I take One Digital Health, and in terms of what we're calling it, I don't mind which way the order of the words goes. I just take it as One Health plus digital aspects, right? So that's technologies. It's basically technological elements added to it. So this seems to massively amplify the potential benefits of One Health by facilitating, so basically improving the capabilities of people working in it, right? So it increases the scale at which policies can be considered and impacts of policies and practices and so on. And it also increases their resolution, right? It means that not only can we work out at scale what's happening, but also we can focus down in, ideally, and this is where surveillance is very important, on the practices of individuals as well as groups and different locations and so on. All of that means crunching huge amounts of data. It's very hard for us to do it. It's much easier for AI to do it. So AI is going to be an important element of One Digital Health. And I think that both the digital, just the straightforward surveillance elements of it, and the introduction of AI raises all sorts of interesting problems that mean that there will be even more social license problems when it comes to looking at One Digital Health. So an important element you might think for achieving social license for One Digital Health is that people understand what's going on in One Digital Health. Then they might agree to it, right? They know what it is they're agreeing to. So if you have, say, generative AI involved in One Health, working out, some answer to some problem, understanding how that answer was generated is a huge problem in AI, right? So this is the sort of explainability problem in AI. We need the outputs of AI to be intelligible to people. Otherwise, they're just presented with, AI says, do this. They have no idea why they should do that, which means that they don't know whether it's something that's agreeable to them from their different moral orientations. So explainability is very important. There's potential for AI to be misaligned, right? Alignment of AI is something a lot of people have worked a lot on. This is aligning the outputs of AI, the way AI acts, to our best understanding of what moral conduct is, right? Given that different stakeholders are going to have different moral orientations, alignment is something that could differ from group to group, culture to culture, even person to person or family to family, particularly in Māori culture. So alignment is a difficult thing to achieve. And there's further speculative problems with AI, such as, well, perhaps not so speculative, people wondering about whether generative AI could become a moral subject as well, right? So whether generative AI is perhaps able to achieve moral agency or moral patiency, something that we might have obligations to. Now that's a tricky thing, because if AI is in the mix, then people have to think about whether AI is something that they trust, right? And to trust someone, often you want to know what their moral orientation is, right? With AI at the moment, we kind of think it has one to the extent that it's aligned, but it probably isn't thinking for itself about these kinds of things. But perhaps it can think for itself. So there's a lot of uncertainty about all of these things, and uncertainty throughout the system about whether AI can actually be trusted, whether it is a sort of thing that is a reasonable thing to trust. Those sorts of things, all of these problems are not good conditions for trust and social license. Right? To achieve social license here, both the normative and the descriptive elements need to be trusted, right? One Digital Health, we need it to be trustworthy. And as I've said, this is, you could just say it's achieving data justice, then it is trustworthy, or it could be following, Calvin and colleagues' great article where they provide all sorts of moral aims for the development of digital One Health, right? Doing all of that. If we assume that explainability, so most of these assume that things like explainability is always going to be possible, but that may not be possible. That may well run out, right? If AI gets complex enough, and we might be at the bottom of a sigmoid curve here in terms of its intelligibility, it may outrun our ability to understand it. So we may run out of the ability to explain. Then we have big problems for trust. How do you trust something when you can't even understand how it makes decisions? At the moment, AI is unpredictable, and some speculate that that unpredictability is an inherent feature of AI. It's hard to trust someone who's inherently unpredictable. Value alignment assumes that we're right about our values. It's always possible, and this is getting speculative as well, that AI could become super moral. It might be doing the right thing, but we don't know it's the right thing because we don't understand that that is the right thing. It's outrun our morality there. So that's a speculative problem. I'm just going to put that up there, and I won't say too much more about it because I'm running out of time. So those are problems for the normative element, right? Achieving that. There's also problems for the descriptive element. Let's imagine that it's trustworthy, that One Digital Health is trustworthy, or any particular initiative is trustworthy. People's folk accounts of trust are going to differ, and also we have different philosophical accounts of trust. So being trustworthy by the lights of a multiplicity of different accounts of trust is going to be a difficult thing to do, but that's just a problem generally for social license. So it might be best to achieve something like incompletely theorized agreement here, right? That people just act as though they trust the system. And this is mostly what we do, I think, with normal health care, right? Say, do you trust the healthcare system? Most people haven't really thought about it. They go along because other people are doing it. They have different reasons to comply with treatments and so on. So they agree for all sorts of different reasons that are they're not sort of coherently theorized. You're not uniting in their reasons. So that might be possible for AI, that people for a range of different reasons, well, AI and One Digital Health, people for a range of different reasons agree to provide their data, to comply with different rules, and suitable sort of behavior that enables One Health to occur is possible. So that may not satisfy the thick account of that, but and it's important to regulate against companies that are cultivating just the mere descriptive elements here, just saying, just getting trust, even though they're not actually trustworthy. So it's important to regulate against those. Okay, so I'll just summarize here, so I'm out of time. Both normative and descriptive elements here are opposing challenges, right? There's good steps to be taken to address them, but all sorts of work is needed here, which is good news for us. And trust requires some degree of trust or uncertainty, right? You trust only when you're uncertain about someone, right? And you're vulnerable toward them. Without either of those things, they're not conditions. Trust isn't a sort of a reasonable thing to apply. So One Digital Health may have too many of these, too much uncertainty. And people may be too vulnerable, particularly different social groups, in relation to One Digital Health, particularly when it comes to AI's use. So those are problems for social license, and that's a problem for One Digital Health. Thank you.
Thank you so much, Dr. Mike King. Excellent presentation there. Well, it got me thinking on a number of points. So, I shan't hog the forum, but I'll just put my thoughts out there. So, for example, if we were to think about social licensing, I just wonder what the relationship is with benefit. If we're saying that in order to have a license, I ought to derive some kind of benefit for providing that sort of license, right? So, and if we think about this kind of benefit, is it going to be an indicator of value alignment or a substitute for value alignment? If we think about it in a contractual sense, so I think that would be the thin description, isn't it? Then value alignment may not be necessary, but then there ought to be some kind of benefit, whether it's in the form of trade, environment, services, or goods. So that I suppose that got me thinking about this notion of benefit, and if we do require benefit, and if we think beyond the human domain, particularly in relation to animals, then it seems to me there's this kind of double exploitation that's going on. So, for example, if we're working with animals or working with microbes, it would be, first of all, an exploitation in terms of how we represent non-human entities. And the way we represent will be linked to the way our intent of exploiting these kinds of entities that we represent. So, so do we actually have any kind of, if we think about it in moralistic terms, social license to firstly represent them in the way they represent them? Or if we are to be consistent with our sustainability agenda, we might need to think about the way we represent, the way we use these kind of data in ways that treat these entities as more than just simply resource. Perhaps there would be a moral imperative to take this sort of approach. Thank you so much, Dr. Mark King, for a very engaging session. Thank you again.
Thank you.
So in the interest of time, we have to press on. As I've mentioned, I will have to delay Zohar's presentation slightly. We have a swap. So Dr. Ziping is going to speak with us, perhaps on, in certain ways, a form of social licensing to do research. So I do wonder if we would think about it in those kind of terms, right? How are we to think about what's morally justified? Is it as a matter of a thin permission that's to be granted, or do we need to, I suppose, increasingly consider what's fair for those who are involved? So Dr. Ziping is going to be presenting in Mandarin. If you have your computer, I'd invite you to log in. You will be able to view the simultaneous translation on your device.
Thank you, Kevin. Because the big data research ethic is such an important and broad, complex topic. I'm still learning on this subject, so I prefer present in Mandarin. So it's much easier for me to deliver it clearly, I think. Okay, sorry for this. 首先，我想从就是我们是谁来说啊，就是其实我是做临床研究背景，那为什么会就是参与到这个健康数据分享这个工作中来呢？我先说一下我的背景哈，就是我是来自深圳市生物医学伦理审查委员会，然后我们是2017年是由深圳市卫健委资助以后成立的，是一个区域的一个综合的伦理服务中心，所以我们当时其实定位呢是要做一些委托，接受一些委托审查，就是一些多中心项目、一些重大项目，还有一些是它没有伦理委员会的一些机构，如果要做研究的话，是需要这个我们可以做这些。另外呢，我们会在深圳市提供对伦理的这相关的人员提供一些培训，还有对我们相关的一些机构提供一些咨询支持，主要是对就是我们政府部门的一个监管提供支持。可以听是吧？好，那其实这是我们的这个机构的背景哈。那其实在健康数据这一块呢，我们主要是另外呢，就是因为深圳其实它整体来说，随着在数据这方面的这个就是政府关注度也高，然后医疗机构还有学术机构还有这些企业来说，都是一些他们都掌握了这些先进的技术，所以它整体来说对这个伦理审查的这个需求特别高，因为特别希望能够促进我们这个机构，促进这个产业的发展，能够提供好伦理服务。那在这个过程中，其实因为我们的角度是作为医学研究的审查， 所以作为一个项目来看的时候，我们最关注的就是从传统的医学研究背景来说，我们要做伦理审查，还有一个就是知情同意。那在我们传统医学研究背景下，和现在基于数据库的这些项目的时候，其实我们就面临了很多的挑战。那我想，其实今天来说，主要其实也是在受到 Kevin 的鼓励吧。其实我们在工作中遇到很多具体的挑战，就是到底伦理审查该怎么做？就是面对这种特殊的这样的基于健康数据的2次使用的情况下，到底知情同意该怎么做？到底该怎么管？那我想主要通过3个案例跟大家来看我们自己的一个经历哈，从易由难。就从最开始，其实我们开始看到的是有一些 researcher， 就是他申请来的项目是基于一些公开的数据库。其实现在国际上、国内这种公开的数据库都非常完善。那这样的一个项目来的时候呢，从他做这些数据分析，然后要完成一个课题的时候，这个项目其实我们当时应该很快就获批了。那在现在我们中国新的法规，新的发布的法规之下，其实我们现在来回头看的话，像这一类课题，如果是基于公开获得的这样的一些数据库，那其实也是匿名化的数据的话，其实是可以走免除审查的这种模式，那也可以就不用考虑知情同意的问题。那我们碰到第2个案例呢，也是我们自己当时收到一个申请，这个申请呢，它是一个学术专业一个组织，那他们手上呢是有受国家卫健委委托，有一个全国的一个心血管方面的一个疾病的监测系统在他们那儿，所以他们那儿有全国175家医院的这个电子病历系统里面的信息都在他们那儿，原始数据也在那儿，所以他们在这里呢就想做2个研究，都是回顾性的去分析，说看这个数据库里，这里面评价一些药物的使用的一些情况，还有一些安全性的一些问题。那它的这个 PI 呢，其实都是来自于一些知名的一些大医院。当时他们找到我们的时候呢，就说这个项目其实是他们学会自己立项以后呢，但是这些 PI 所在的机构就所在的医院并不愿意给他们审这个项目，因为他们认为这个数据库不是他们医院的数据库，虽然这个 PI 是这个医院的，所以当时因为我们是区域伦理，就找到我们区域伦理来审查。那其实当时我们就觉得，这就在这个受理阶段就觉得这确实现在一个新情况，因为数据库这种情况下的话，可能它是来源于很多家机构，不像我们传统医疗机构里，可能一个 PI 它可能就是这家医院的一个做申请的话，他在这家医院开展，所以他在这家医院申请。但真的像这种情况，跨机构的这种项目呢，那他到底向谁申请呢？其实我们作为区域伦理，是确实有责任去承担这个审查，而且现在在我们国家新的法规里这块也确实有明确，如果说没有伦理委员会的，确实可以委托认为有资质、有能力的伦理委员会、其他机构伦理委员会或者区域伦理委员会来做审查，而且同时要做持续审查。那在这个项目过程中，我们也在想哈，就是这也是一个常见的。现在因为这种就是跨机构合作越来越多，不仅仅是数据库的问题，可能这个数据库在这个地方，但是可能它因为有些数据的分析的挖掘的这个技术，可能是有些科研院所甚至是企业，所以它这种跨机构的这种合作的时候，那到底项目该由哪审呢？其实我们就在这个案例的时候，我们就在思考，一个呢说要考虑这个机构的审查能力，它之前有没有审查这一类数据库挖掘的这种经验，那有没有这种委员背景，然后它审查的效率怎么样，然后里面有没有利益冲突这些问题。那一个呢，就传统来说，大家肯定我们因为中国的法规来说是机构责任制，就是伦理审查的这个批件是哪发的，是由哪来负责。那包括说这个机构，就是这个研究者他在哪个单位，自己这个机构也是一个主体责任。所以当时觉得可能传统上来说，大家机构如果能力强的，他肯定还是要自己审。那另外一个就是这种刚才这种他自己就没有伦理委员会，或者他觉得确实不具备这个能力来审的，那他可能也可以委托外部机构来审。还有一个就是我们也想，其实现在各家都有，那还有一个就各家审各家的，那审以后它能有一个互认的机制，就相互，但这样也能够提高速度，就是它可能主审的审的会更细一些，那其他的单位可能就可以走一个备案的流程。这是就是针对这个案例我们当时想到的。还有一个呢是在申请材料中，虽然其实我们在就是 我们去伦理审查的这个制度建设过程中，其实我们都有受理的清单，但是对这样一个基于数据库的项目来的时候，就会发现它很多是不适用的。就是我们如果是医疗机构也好，或者科研院所，如果是已有的制度和这种基于新的数据库的这样的一个项目申请的时候，我们是专门做了一个受理清单，就里面也设计了一个这类项目的审查的就是那个表格。然后在这个过程中，我们就发现，就我们在正式审查前，我们在确认我们要不要正式受理之前，其实发现确实它跟我们传统的医学研究还是有很多不一样的。第一个是说，就是我们当然是接受了这个项目的委托审查，那其他机构他要不要接受委托审查？他以什么形式接受？是这个 PI 自己找来就可以吗？还是其实现在法规已经也清晰了？就是我们当时做这个 case 的时候，法规还没那么清晰，就其实是要接受书面委托，而且是机构委托机构。不是个人来委托机构来做这个受理。另外一个呢，就是我们现在其实都要求我们每一个项目审查之前，它的科学审查必须有一个有一个证件吧，有一个就是能证明这个是有科学审查的这样的一个流程，而且获得立项了。那像这个项目，其实它是学会自发的，这个里面的科学审查由谁来做？包括它的审查类型。那我们国家的法规是说，伦理审查项目是基本上是以会议审查为主。那像这些项目是会议审查还是走快速审查？那包括说，这个项目里，其实我们当时还启动了就是外部顾问的制度，因为我们自己的委员里也没有数据库方面的专家。所以这个也是想跟大家分享，就是我们其实真正在做这些基于数据库的这些项目审查的时候，其实就在确认受理阶段，其实也是有好多细节要去考虑的。那在真正就是这个项目受理以后，就会发现其实它跟我们传统的就是一个研究项目的审查的要点又不一样了。其实我们一个项目审查的时候，我们看它这种就是它的科学性或者它的社会价值这些方面以外，这个项目里。和第一个项目的不一样，我自己觉得哈，就是因为我们不仅仅看项目，我们还要看这个数据库，这个数据库的管理是什么样的，这个数据库的这个管理的运行的这个团队的人员的资质是怎么样的，这个数据是从哪儿来的，里面有没有这些敏感信息，如果有的话，这些敏感信息有没有经过处理，然后它的这个整体这个数据库的这个安全性怎么样，然后里面特别是它还有这些数据的有没有获得知情同意。因为像这个 case， 因为它本身是匿名数，就是从各个医院系统就抓取出来的数据，而且它其实还有一个，我们当时在给这个项目就没有直接批准，是给他了一个就是让他再交补充材料的这样的一个有条件的这样的一个给他反馈一些意见，因为我们当时担心的是这些数据本身来源。并不是做科研的目的，所以一个当时没有知情同意，一个国家卫健委知不知情，就其实作为这个学会或者这个系统的，就是他手上有这个数据，他其实有的权限是在履行这个行政职务，并没有说你获得授权可以去做研究，所以当时我们是要求他一定要获得国家卫健委的这个同意，这个数据才可以去做研究，这是一方面。那我觉得再一个，其实我们在后面就会碰到大量的，就现在因为现在这个信息化水平是很高，各个医院的这个信息化的这个建设也很多，那各个医院都在想我怎么样能让我的数据能更好的被医生能够用起来。其实各个医院都在建各种各样的数据库，我们。同时，其实包括我们自己深圳市也有我们自己的医学信息中心，在这个过程中，我们就去看这些数据的特点。一个它的来源其实是非常多的，有我们可能routine日常的我们就诊的这些各方面的各种各样的这些就诊信息，也有一些就是我们医院自己研究者发起的一些项目，他收集到的一些数据也在这些库里。另外还有一些可能我们现在各个医院也都建了样本库，那这些样本库里的数据也可以跟我们这些数据中心能够连接起来。另外呢，还有现在有很多这个可穿戴产品，确实我们现在看到有些作为就是辅助的，大家也会用这些数据里面日常的一些检测信息也能进到这个库里。那像包括我们会看到，就是这些数据库的使用者来说，除了我们的医生，就是医院的职工以外，其实会发现还有我们很多合作单位的，就是我们科研院所的这些高校的，真正是搞数据科学的、搞统计的、搞这些技术分析的、搞生物信息分析的，在这种情况下就会看到。 就是这种跨多学科的这种交叉，然后里面研究的问题、研究的类型，其实都是非常复杂和不一样的，甚至有些项目缘起可能是回顾性，但它后续可能还要去随访，还要去追踪。那在这个过程中，我们就体会到，可能就除了我们刚才想到的，作为一个数据库要建立的时候，你数据库要具备的那些能力以外，因为这个它和又不一样，它这个数据库是真的是要去共享的，那你这个里面就对共享的这种机制要求就很高了，就是到底是外部的这个 researcher 他怎么样能够进入到这个平台，然后从这个平台里怎么样能够拿到这些脱敏的数据，然后这些方面其实我们当时就是考虑比较多的。那这是在伦理审查方面，那其实在这个数据库到现在来说，我们觉得最大的挑战是知情同意这一块，因为我们传统的医学研究里，我们肯定就是具体的知情同意。那现在像这种项目里，到底怎么样知情同意？是现在因为大家都提倡是不是能够电子知情、远程的这样知情，还是说我们就是有这种分层的知情同意，或者如果用到它数据的时候再去回顾性的知情，还是说我们大家现在也讨论最多的是不是能够用这种就是广泛知情同意，或者就跟我们甚至有些其实很多大夫觉得我们是不是就可以免知情同意？还有这种国际上也提出的这种知情选择退出，还有动态知情，这个其实是我们到现在我觉得也是希望后续待会儿也希望有各位在座的讲者能够给我们一些指导，就是真正就知情同意应该怎么做？因为现在知情同意从法规的角度，其实它是很确定的，就是要具体的知情同意，但其实真正在这些海量的信息在不断的涌进来的，其实也能觉得就是知情这种方式其实是很难的。而且你就同意你将来他到底要怎么做，用来这些数据做什么，其实也不是那么具体的情况下，其实这个知情同意就是它的效应又有多少，这些其实就困难，应该说是困难重重吧。那再就是我们在做这个工作的时候，就特别多的一个体会，就是除了你看像传统的临床研究，我们除了想到说它的项目的审查、知情同意以外，这种数据库里面其实这种管理就特别重要，因为里面大家的角色不同。当时我们在学习国外很多他们用的肯定是有那些 controller 或者 processor， 就他用的那些就是定义处理者、控制者。但是我觉得在我们国内，我们也想了很多，就到底该怎么用，因为这些数据来说。数据中心其实它只是一个，不知道这个定义准不准确，我们是这么划分啊，它是一个作为数据中心，作为一个数据的提供者，那其实使用者还是我们的这个就是各方吧，就是医院呀、科研院所呀，然后企业这些。那另外还有一个监管方，因为监管方其实我们当时考虑是说能不能就是由我们卫健委做一个数据的管理的这样的一个委员会，这个委员会里面他会就是把这个流程都制定清楚，特别是有一个受理申请的过程。就除了其实伦理委员会是不够的，我们当时想表达的意思就是，其实应该还有一个，就是他对这个数据审核的一个委员会，他同不同意这个数据到底这么去用有没有价值，同不同意？另外呢还有一个是在数据库里面的数据，就有些 PI 他提出一些 request 的时候，其实这个数据库里的信息能不能满足这块他的这个要求，其实都需要一些沟通交流。就这一块其实有一个评估，就是我们希望就是有一个这样的 committee 去做这个工作。那其实对这个 data center 的要求应该是更高的，就它应该是整体来说，无论从硬件、人员，包括它的整体的这种就是机制都要特别清晰。除了保证我们特别强调的安全性以外，它一定还是得提供这个专业服务。这是我们当时就是觉得这种不同的角色，它承担的责任要划分清楚。再就是整个这个全过程中间，到底从这个数据从一开始这个项目没有，到从立项的过程中，到最后这个项目实施完，到最后做完，整个这个全过程中间应该怎么去管，伦理在里面又是什么角色，我们就更深刻的体会到，其实光靠伦理审查肯定是不够的。一个数据库里面基于数据库的项目，其实它也有一个立项过程，就这个项目它的这个前期就是数据审核的这个过程，伦理审核的过程，那科学性的审核，那到了最后还有包括我们的这个 使用人员的他的培训，就他的资质，他能不能把这个数据用好，他会不会把这个数据给又导出去了，或者什么样，就这些其实就在立项还有包括整个这个过程中，其实也觉得是有好多细节的地方，其实也是就是这是我们当时在梳理想把这个数据库给大家用好的时候做的一些工作。那我是后来就是在整个这个过程中看到英国的这个健康数据这个应该是联文，就它里面其实我觉得有些是我们特别值得借鉴的一个，这个应该也是在国际上通用的，他们提出来这个5个安全方面，就他考虑到相关的人就一定要合适，就是他要 qualify， 然后相关这个项目要是合理的，然后它的这个数据也是安全的，然后整个这个设施也能保证就是不会有泄露隐私呀这些情况，那还有包括它的产出。那再一个，我看到他们，我觉得这个图其实是特别，就给我启发特别大。我觉得它真的是，就是不仅仅我们以前看到的，肯定主要是就数据中心和我们研究者这个关系，它这里面其实还增加了患者这一块、临床大夫这一块，其实这2个角色也是非常重要的。就一方面，其实它是数据的提供者，就是从源头的提供者；另外一方面，它也是要有这个结果反馈的，是吧？也是回到他们。其实我是觉得这个图可能在我们后续的工作中，应该是我们会去再想想怎么能跟我们现在的工作结合起来。那就基于这些吧，其实我觉得，就体会到哈，就是现在其实我们就以前的这个传统的医学研究，我们做伦理审查的时候，真的是因为现在这种基于健康数据的研究带来了很多变化。一个就是最直接的变化，现在很多表述上，其实以前都是 subject， 因为做的就是 clinical trial， 现在就变成了这个研究参与者。另外，我们以前特别强调个体的自主性，那现在我就是因为在接触这个健康数据的这些研究的这种伦理学习过程中，确实体会到它其实更多的考虑的是一个公共的一个利益，所以里面大家确实得就是有一个团结互助的这样的一个背景，就不能光考虑个人的一些利益。可惜有时候可能公共利益可能当时看不到，甚至公共利益最后其实可能大家都能受益。另外就是我刚才也说过的，就是我们可能以前的具体执行统一到现在怎么样做一个规范的能够合法又能用的一个真正的一个执行统一的模式。还有就最深的一个体会，就真的是光靠伦理审查肯定不够，一定是需要多方的这种管理。那其实我觉得在学习过程中也有看到更大的，其实这可能是真正Kevin希望就是我们这个可能大家都很专业来了解的，其实是真正数据伦理的这些背景，其实能够合乎伦理的来用这些数据。然后我们在学习过程中也看到，其实国际应该各个国家都发布了这个数据伦理的这些框架原则。那特别是在英国，他们专门有生物医学领域的这个就是健康数据这些怎么用，我觉得也是就更强调了，就其实就是尊重，其实我们看的是数据，但其实是要尊重这个数据背后的这个个人，然后要保证大家都参与，然后能够在决策过程中都更能够责任共担。包括英国也专门有一个就是对数据的这种指引吧，就这些我觉得都是也是对我们自己就是在做这些现在这些健康数据的使用过程中的一些都受到很多启发。另外我觉得可能就是最后想说的哈，就是其实最终我们也看到很多原则共识，国际国内都有很多，但我们怎么样让它落地，其实真真实实的，我觉得这个考虑点确实跟以前传统的是不一样的。一个呢，就是我觉得真的是要最底线，我们是要符合法律伦理的这些规范，而且得与时俱进，得有一些变化。另外，我们最主要是要找到一个可以操作的一个这种一个模式和而且还得比较高效。我觉得我们之前的那个设计就是比较繁琐，就不够简洁，所以这个也是我其实困扰了我很久，就是特别希望就是我们这边数据库把它建好，就是能让该用的人能够高效的去使用。另外一个我觉得就是真的还是我们其实希望我们用数据来解决医学的问题，然后能够让大家就是在这就以应用为出发点吧，然后能够建立比较好的这样的一个生态系统，然后也是最后还是说，因为这个数据相关方太多了，所以还是大家得责任共担，然后共建共享。 我最后就是感谢我们这个，其实我们区轮里的工作主要都是也有我们北大丛雅丽老师的还有我们深圳市的同召一起做的。我想就是我要今天跟大家介绍的内容就这些，谢谢凯文。
Thank you so much, Ziping, for the excellent presentation. I am delighted now to welcome my colleague who will be sharing with us some of his prior research on One Health. So Zohar has thought quite a lot about One Health, certainly in terms of its ethical dimensions. Very curious to hear what he has to say about the digital aspects of One Health, depending on what we consider to be digital One Health or One Digital Health. Still very much, I would think, a contested term. So with this, Dr. Zohar Lederman, welcome. And beautiful presentation slides. I like the dynamic feature. Over to you, Zohar. Thanks very much.
Yeah, thank you. Basically my main point, which is I'm going to make very simplistic, is that what I think about One Health, or what I think about digital One Health, is exactly what I think about One Health. And so it's very much saying what Mike was saying, just much less, I think, in a sophisticated way. So I've been working on One Health, or some of us in this room have been working on about the ethics of One Health for a long time now. And what I think frustrates us is that we have the declarations of One Health and what One Health is all about, which is, or what it should be about, which is the health of and well-being of animals and the environment. But oftentimes what we discovered is that that was not the case. So when we would go to One Health conferences, when we look at the publications, and now there are a bunch of publications, what we realize is nobody really cares about the animals or the environment. So people only focus on humans and human health and human well-being. And so really what you get is just public health named One Health. And we are not happy about that. And what I fear and what I want to raise here, just looking at two examples, is that there's going to be the same thing with digital One Health. And I just want to warn against that, and basically saying, if it's going to be the same thing, then I don't see the benefit of talking and doing digital One Health, because it's really about digital public health, which is all about humans. And from what I could see, and Calvin, correct me if I'm wrong, this whole notion of digital One Health started with a piece by Deborah, I'm forgetting her last name, but Deborah, and she suggests, or she actually uses the ethics to say that, maybe we should think about digital One Health. Deborah Lund, the digital One Health, to think about the ethical status, the ethical value, or what we owe, or the world we share with animals and other non-humans creatures. And I think that's a step in the right direction. But then for some reason, the literature kind of twist or change the direction to, again, just think about humans. So this is one example by some people in Israel writing about One Digital Health. And, regardless of the fact that they misconstrued the history of One Health, saying that it started with the Manhattan Principles in New York, which is really one subset of One Health movement approach. And they are also can be guilty for making the same sin as a lot of other One Health practitioners, focusing on infectious diseases, whereas people who do One Health often complain about this focus on infectious disease, whereas, as Calvin mentioned, One Health is much more. And, we often focus on hotspots, whether maybe we should also focus on cold spots and more about building resilience rather than just focusing on what's wrong about health and where disease can come from rather than how we improve health or maintain or sustain health. But what really, I guess, bothers me, and I think should be a reason for concern, is again this emphasis on humans. So here, in this case, they argue, right? So digital One Health is a collaboration between informatics and One Health, which is fine. I have nothing smart to say about that. But it sounds like the real interest is about individual health and well-being, and by this individual means humans rather than non-humans actors. And again, here they are making a weird distinction, or rather the lack of distinction between different populations, so human population and non-human population. And I think this requires much more unpacking than they do here. And I'm not saying there's no mention of the well-being or health of non-human actors, but even when there is, and this is one example, I will give another one soon, there's no serious discussion of it, right? So they're basically paying lip service to this notion of One Health, the moral notion or moral core of One Health, but without due justice. Excuse me for the pun. So here in point 2, you see an example of that, how digital systems may support and improve the health and wellness of humans and animals. But why are we caring about, or should we care about the human and health and wellness of humans and animals, other than just optimizing the health of humans? Are we caring for animals for their own sake? And again, when they talk about animal health here, they seem to focus on pets, livestock, and food, whereas when they talk about human health, they talk about human health, care, and well-being. So I don't see an equivalency here. I see that human animal considerations really take the inferior spot, and the priority is really to human health, human care, well-being, meaning it's a very anthropocentric approach to health. Another wise person writing about digital One Health, I think, is again maybe making an attempt to think more seriously about the moral aspects of digital One Health, but without really focusing on or expanding on it from an ethical perspective. So natural habitats, very important. Secure the health and well-being of all living things, extremely important and worthwhile. But when it comes to the real core of the argument, focusing, for instance, about digital divide, the way I understand it, for instance, or at least, digital divide is not a concern between humans and animals, arguably is about different humans, right? So again, the ethical concern here is more about justice, and we saw that also in the article that we are supposed to rely on. Justice between humans is all good and very important, but that's not what One Health is about, or it should be about. So public health can do that, doesn't need the name or title of One Health, and it doesn't need people working on the ethics of One Health. And I think that this is my last point. I think one of the encouraging advancement in the literature of One Health, in the field of One Health, is this establishment of the WHO expert group on One Health, and we have at least one member of the group here, which I'm happy to see, and it'd be interesting to hear what he thinks about it. But I think what at least I'm happy about is what they say about point 3. So they realize, they acknowledge the intrinsic value of all living things, and it seems that they are really serious about promoting this idea and implementing it in public policy. And again, it would be interesting to hear if that's correct. But I think that if we are serious about One Health, and if we are serious about digital One Health, that should be the guiding principle. So in the bioethics literature, at least, which, by the way, it's very concerning that people who write about digital One Health don't mention at all, or don't seem to acknowledge or to know. So there is a debate whether we need a grand philosophy to justify this, granting intrinsic value to all human beings. That's fine. I don't think we need that, or at least, ethicists could work on it while the science of One Health is being done. But at least the assumption should be this, or something similar, that it's not about anthropocentrism, moral anthropocentrism. It's about something more. So either thinking about the moral value of ecosystems, think about moral value of the planet, think about moral value of humans. That should be the starting point of a One Health approach to seeing things and seeing health and disease. Whereas if we want to rely on humans specifically, then we don't need One Health. It just creates confusion. Public health is good enough for that. And a way to think about it or implement it in the field of digital health. So just when was it, a month ago, or even less than a month ago, there was a Calvin organized conference on social listening. So, think about how, and going back to the ethic, to the justice approach of how it's important to be, for members to be visible, and for policy to be anti-discriminatory. Think about, the invisibility of animals when it comes to health policy and the discriminatory nature of health policy. So, when it comes to health policy, rats are usually invisible, right? So as we speak, there is a rat tsar in New York City deciding how to kill all rats, basically, in New York City. Whereas we often forget that, rats, at the end of the day, they transmit disease. They are dirty because humans are dirty and they have disease. Right? The same thing, we were all taught to think about or to perceive mosquitoes as the great killers of humanity. Whereas, think about all the encounters you had with mosquitoes that didn't lead to disease and to mortality and morbidity. So again, just to emphasize, the point here is, if we are serious about One Health, if we are serious about digital One Health, it means being serious about the moral foundation of One Health, which is considering the moral value, however you want to define it or justify it, of non-human actors. That's it.
Yeah, thank you so much. Well, the political economy of One Health. So, ladies and gentlemen, if you join me again in thanking Dr. Zohar Lederman. Thank you. For our next speaker, I'm delighted to invite to the floor an old friend, Dr. Claire Lajeunesse from INSERM. INSERM, perhaps we'll leave Claire to introduce the French Institute for Promoting Research. As far as Claire is concerned, she's done a lot of work, particularly in the international law aspects of One Health. And she also, together with other colleagues, put together a very instructive volume on how we should think about big data in and environmental One Health sort of context. So welcome, Dr. Laj.
Thank you very much. Thank you very much for the invitation. Thank you to the organizers. And I will try to present something at the macro level, the One Health governance framework regarding antimicrobial resistance. So I would like to start with the global action plan of the WHO on antimicrobial resistance. And with that, it has been developed with an overall goal, ensuring continuity of the ability to treat and prevent infectious diseases with effective and safe medicines. This is the point, and accessible to all. And regarding data, I want to insist on the objective 2 of the Global Action Plan, which is strengthen the knowledge and evidence base through surveillance and research. And it came from the realization that many gaps in information on antimicrobial resistance are there, and especially when it comes to pathogen having global health importance. The lack of agreed standard for collection of data and reporting. We will insist on reporting and monitoring regarding human health, and we will discuss about that importance of human health and the health of animals. No standards across medical, veterinary, and agricultural sectors. So this is really the One Health concept, and no global forum for the rapid sharing on information on antimicrobial resistance. So that was the point of the development of the Global Action Plan, developed by WHO, but I insist on the fact that when the World Health Assembly adopted the resolution to develop the Global Action Plan, the others UN organizations such as FAO, but also, sorry, this is not, the other one is not a UN organization, this is at that time, it was called OIE, and now it is the World Organization for Animal Health. They were into the loop to develop the further documents coming from the Global Action Plan. So from that global plan, what has been decided and accepted by the WHO member states was to develop within 2 years a national action plan on antimicrobial resistance. And as you can see, there is a manual to help the states to develop national action plans. And you can see that the WHO is not alone here mentioned, but you have the OIE and the FAO. And this stated the core component of a national action plan. So you have the strategic plan, operational plan, but what is interesting here regarding data is the monitoring and evaluation plan, and especially the need for performance indicators and targets and timelines, and the fact that we have to do the data collection and reporting methods. But here it was, nothing more, it was not precise, and it has been said to be an iterative process. So you can see this is version 1. To my knowledge, there is no other version of that manual, but many discussions came on later on. And I want to mention one, which is the Interagency Coordination Group on Antimicrobial Resistance. That group has been created by the Secretary General of the UN General Assembly. And later on, so I think it was, I'm sure it was in 2018, the group gave information about the data needed for the implementation of the National Action Plan. So here, this is interesting because the approach is already a One Health approach, and the group said that it was important to have information on the local burden of AMR in humans, animals, food chain, and plants. So the indicators were the morbidity, the mortality, and the financial costs that you cannot avoid, the access to antibiotics, the sale and use, so the of antimicrobial, for humans, but only animals. So we spoke about the veterinary sectors and plants, which is agriculture. I think we will hear a presentation about agriculture later on. And the question of monitoring the residues of antibiotics, and I will detail further the development of legislation on that, and the behavior in the use of antimicrobials and its drivers. So here it's calling for the integration of social sciences into the development of the data. Data are quantitative, but they should be qualitative as well, and involve the behavior of people and maybe of the veterinary services or the sector of the agriculture. So what are they for? The National Action Plan doesn't mean anything without any monitoring, and the point was to address the implementation of the National Action Plan and to see the global plan, the what was happening at the regional level. So it's a construction, so it's in between, as you know, the international level and the national level. But it's a creation, and I will show what happened in ASEAN, a creation of a network of partners at the regional level to check or to report the antimicrobial resistance and use, and to see what to monitor the evolution. To monitor the evolution with the Sustainable Development Goals. So here you have ethical questions that have been presented in the presentation by Dr. Jiping about transparency and accountability to stakeholders. So we are in between the ethical questions and the legal questions. And the point for the monitoring is to inform decision-making. And what has been said is it was useful for the decision makers to identify the success factors and to have a basis for learning and to learn from all the errors that were made and to make improvements. So for the indicators, because we are speaking about data, for the indicators, what has been said later on by the WHO, and sorry, I didn't indicate the source, but it's a report from the WHO of 2019. The point here is to have indicators to evaluate, as I said, qualitative and quantitative, but to know what kind of activities have been decided to implement the National Action Plan, to see what are the outputs, to see what kind of intervention had success, were successful or not, and to see the impact. And the impact is detailed to be based on smart indicators. So that is to say that are specific, that are measurable, and I will come back to that for the legislation because it's not mentioned at all into the legislation at the end, achievable, relevant, and time-bound. So then what is it about? It's going into surveillance systems and monitoring mechanism. At the time of the adoption of the Global Action Plan, the WHO launched the Global Antimicrobial Resistance and New Surveillance System. So this is for countries, territories, and areas. And here you can see the countries involved into the program regarding the antimicrobial resistance and the use or the consumption. This is the orange one, so not so many countries. and those that are not enrolled. And in the reports, you have, so it started with a focus on common human bacterial pathogens. So it's answering a bit the questions you were speaking about. So it started with the human questions. And then the second step from 2020 to 2022 decided to include the antimicrobial consumption or the question of fungi and One Health surveillance model. So it's going from, because the different organizations started to develop together their thoughts about how to include One Health approach regarding antimicrobial resistance. So it was iterative, and now from 2022, they have that 5 years of development of national plan and surveillance data. And so they are going back to what has been done and reflecting on the issues. And as you can see, I hope you can see, the reports are about the antibiotics and the combinations of antibiotics used, and also the kind of category of consumption on the right side, and the routes, oral routes, and inhalatory. So you have many details about the consumption and the use of antibiotics, and this is how the countries are reporting to GLAS. You have different modules. I will just precise some of them. So you have the use and consumption, and for some, you can see on the routine surveillance surveys or focused surveillance. I want to insist on the One Health surveillance model, which is on one model, which is E. coli. The model is called tricycle because it's focusing on E. coli in humans, animals, and the environment. So all together, and this is a way to monitor, to have a model of One Health integration of surveillance. And so you can see there are many layers of system of surveillance. Another one is tracking antimicrobial resistance country self-assessment survey. And here you have many questions. So do you have a national plan? Yes, no. How is it developed? So you have many questions. And this is about the collaboration, coordination on One Health, and it's declarative, but anyway, it's existing, which is interesting. And when it comes to the environment, the questions was, is the environment actively involved into the question of antimicrobial resistance surveillance? Here you can see the answers. And I think the question is probably too broad, so we have to dig in to understand in which sense we are speaking about actively involved, what does it mean for the different states. And I think this is a point of research that is interesting to know. And then you have the Global Health Observatory with the country profiles. And here the countries are declaring the case reported at the hospital, in the at the very local level, the district dispensaries, and you have the age, gender. So this is about the personal questions and privacy. And you have the number of tested patients, number of infected patients. I took Thailand because I know that Serge later on will present things about the field, from the field. And so you have all those layers of declaration and surveillance systems. What about the regional strategies? There is an ASEAN strategic framework using the One Health approach. So this is important. And here the question is to have, this is really One Health, at least in the way it is written, because it calls for a comprehensive, multi-sectoral and multidisciplinary engagement. And it's stating for the different activities, as you can see, human, animal, and agriculture, food safety or the environment. You have the work done into the labs and what is monitored or reported or the kind of data collected. And another example is the One Health Action Plan regarding antimicrobial resistance, in Europe. And this one has been reaffirmed, and with Europe saying that we need to implement further the legislation on monitoring the AMR, and especially take into account the new scientific development and data collection. So it means that we have to use science to put that into the legislation or policies. So it's like that. You have the different levels of decision makings, and this is coming from the WHO, the different sectors involved, and it's a question, as the WHO put it, it's a question of political commitment, and to foster that political commitment, the legal instruments have been pointed out as a solution, or at least a way to improve the political commitment. And for the practical management here that you can see, the monitoring and the way to see how things are implemented is a good way to follow up the different policies and legal instruments. So about the legal instruments, I want to mention something that has been done by the FAO. The FAO developed a methodology to analyze AMR relevant legislation in the food and agriculture sector at the beginning. And then it led to something I had the opportunity to take part. This is a quadripartite One Health legislative assessment tool for antimicrobial resistance. This is the title now, official title. It has been launched last week. And after a lot of discussions among the FAO, so sorry, I forgot to mention the tripartite became the quadripartite with the involvement of the United Nations Environment Programme. So it has changed a bit because the environment is now officially involved into the loop. And when it comes to the way the work has been done, this is what I would like to insist on. The questions was the analysis of the existing legislation relevant for the environment, soil or waste. And the questions were written like that. Where can this be regulated? So, for example, environment-related legislation and so on. What should be identified, either specific legislation or standards regulating the disposal of waste, and so on and so forth. So you have all the questions of what is existing into the legal framework. And it's going on with the One Health joint plan of action of the quadripartite, especially it's connected with the action 5.1, sorry for the title, to strengthen the capacity and knowledge of country to prioritize and implement context-specific, this is the important thing, collaborative One Health work. And it's to provide guidance for country. And sorry if we don't see well the theory of change of OLEP. Zohar spoke about OLEP just before. So there is a theory of change. You have the pathway 1 regarding the policy and legislation, the pathway 3 regarding the the data and evidence-based. And what is important for me is the dialogue between science and policy that is shown here as important as well in this theory of change. And for me, the critical point is you have on the left the kind of questions that were asked in the document, the legislative tool. And for me, this is not exactly the way it should be taken, I mean, considered. This is coming from the existing legal provision, and we are speaking about the source of AMR, when I think it would be very interesting to have to consider the source of AMR first and to see how we can introduce that into the law. So to reinforce the dialogue from science to policy and not the other way around. And for me, the questions should be maybe the same, but then answers from practitioners and researchers. Where do we get the data? What kind of, for example, regarding waste, what kind of waste from hospitals, sewage, what should be measured? This is because you have in the global action plan all the questions about measures monitoring, but then in the legislation it's disappearing. So we have a gap between what has been said into the global action plan and what is said into the legislation. We don't know how to do in reality. And for me, this is not a tool if you don't know how to do. And which scale should be used, the frequency of measures, feasibility, and for a real monitoring and enforcement of the law, for me, this should be considered and go back to the legislation and integrated really into the legislation, maybe because if there is no way for departments to measure, then there is no interest in saying, oh, you should put that into your legislation. But if you cannot apply that, it has absolutely no interest, and we should know how to measure it as well. The instruments are important. This is also maybe a question of equity between the populations. And this is just to reflect on something regarding the ethical use of antibiotics. On the left, you have something done by the Veterinary Council of Ireland. It was just because it was interesting to see, is the treatment useful? Can we suggest another one? Use less antibiotics? And what has been proposed into a paper, it was just for the reflection about the empirical evidence needed to justify One Health policies. The questions were, who is responsible for changing practices? I don't think we can answer it like that, but for me, the question should probably be, okay, the question of responsibility, is it possible to involve the question of responsibility regarding AMR? Because we know that it's a global concern. So on the legal perspective, responsibility is of course, one of the questions to be asked. And about the bad outcomes, if we can say so, who is responsible or accountable, and how can we involve that into the legislation? I don't have any answer. It's to just for the reflection. And I thank you for your attention.
Thank you so much, Dr. Lajane. Some very important lessons for us to, and issues for us to consider, particularly for some of my colleagues teaching the public health law course, all the legislative challenges, as you've mentioned. Well, I guess not surprisingly, we are confronted with lots of collective action problems, which is what our next speaker is going to share with us on. Pleased to have with us Dr. Isaac Weldon from University of Cambridge, the Center for Law, Medicine, and Life Sciences. Welcome, Isaac.
Okay, thank you. Thank you, Calvin. And I'm honored to be here presenting about my research on antimicrobial resistance and collective action problems. So I think I'll just jump into it because I know we're a little bit behind schedule, and I'm also quite hungry and excited to get to lunch. So let me just say that I'll be presenting on some research that is nearing completion that looks at analyzing AMR as a series of collective action problems. And then I also want to touch on how this is feeding into research looking at global science policy interfaces for health for AMR, but also in the context of the pandemic instrument negotiations that are ongoing. So this project initially started a couple of years ago, and with some really wonderful collaborators, we were sitting around trying to figure out what our project was going to be on, and we kind of had there was a sense of confusion and borderline frustration with the way that AMR was kind of presented as this monolithic problem, and it's an immense and imminent problem and challenge that we face. But in the literature, we often found that it was characterized as a global collective action problem without really fleshing out what that means and without really indicating what the value gained is by labeling AMR as a collective action problem. As well, it's very common to treat antimicrobial effectiveness as a global common pool resource, which is quite apparent the more that we use this antibiotics, the more likely it is that resistance will occur, which depletes the overall stock of antimicrobial effectiveness. But beyond that, there are many other facets of AMR that aren't really elaborated in the language of collective action. And so we set out initially to try to come up with a range of different conceptions of AMR and translate these into collective action problems that can be used as sites for intervention, policy intervention at the global and national levels. And so we begin by parsing out different facets of AMR as a social challenge. We talk about AMR being a global collective action problem, but really it presents at least four different social challenges. And that includes improving access for the millions of people that don't have access to effective antibiotics, while also balancing conservation to ensure that we protect this precious resource for current and future generations. And then we also need innovation to replenish the depleting stock of these time-limited medicines. And then underpinning all of this, global prevention efforts can reduce our reliance on antibiotics as well. So these are really broad categories of where various governance challenges come to the fore. And within these areas, there are many different facets of policy challenges. And we recognize that it's not just a common pool resource challenge, but there are a series of interdependent collective action problems around both common and public goods for governance in this space. But these different collective action problems aren't really identified in the literature as sites for policy intervention. And so we start by setting out with this quasi-Delphi method where we got together to try to define what these different collective action problems could be and what they would look like. And so the process kind of looked like something like this, where we define this specific governance challenge, which could be thought of as a problem of inaction or suboptimal action. And so the example for AMR, one example would be the insufficient investment in antimicrobial discovery, so new medicines. We need new medicines to replenish the time-limited stock of the common pool resource of antimicrobial effectiveness. And so this is a question not about use of the common pool, but how the common pool is sustained over time. And unlike questions about the common pool resource challenge or the tragedy of the commons, as it's commonly called, this question of how we develop new antimicrobials presents a unique situation that can be conceptualized as a volunteer's dilemma, where the cost of developing a new antimicrobial is borne by the person who volunteers, or the firm or the country that volunteers to pay for it. But the benefits of new antimicrobial discovery are diffuse to entire populations. And so there's this question of how do we incentivize antimicrobial development through funding, push and pull mechanisms that's qualitatively different than the question of how do we ensure that conservation is achieved through changing behaviors around use. And so this is just one example, but this thought process we applied to those different areas that I just mentioned to come up with a range of different collective action problems where we can identify unique questions about payoffs and structures, the structure of payoffs and benefits based on the relationship between individual action and the collective outcome. And so we can identify different coordination games that, where it's not necessarily that we're trying to achieve an optimal outcome, but trying to avoid a mutually desired or undesirable outcome. And a common coordination challenge is, do we drive on the left side of the road or do we drive on the right side of the road? Where, really it doesn't matter. There's no strong preference, but there is a preference that we all drive on the same side of the road in any given place. A weakest link problem, you can conceptualize this as, the collective effort is only as strong as the weakest link in the chain. So all these different situations present a unique challenge for achieving cooperation. And so that was the first part of our research, and this paper is in the final stages of completion, which means that it's in the first stages of rejection at different journals. But we're working on revisions and trying to get it published to just provide a little bit more clarity and nuance and precision when we talk about AMR as a global collective action problem. So the next step, because it's not enough just to say that we have a bunch of different problems, we need to figure out how do we solve these problems and how do we turn situations of collective inaction into collective solutions. And it's our hypothesis that this more nuanced and precise use of collective action theory will be able to allow us to mobilize international law to address these specific collective action problems. And so we can ask, how has international law been used to mobilize, how has it been used to address similar collective action problems in other issue areas like environmental law, climate and biodiversity governance? I'm just going to focus in now on a few different collective action problems that we identified as they relate to surveillance of antimicrobial resistance. Largely feeding into the research is kind of being directed towards science policy interfaces for AMR. And that's because one of the challenges in looking to other areas of international law is that we face similar collective action problems, but we also struggle to solve them. And it's very difficult to find and identify success. And so a lot of it is focusing in on specific collective action problems that we seem to be doing well in. And that, of all the different things we can learn from environmental law, for example, is that the one area that environmental law seems to be doing well in is creating science policy interfaces. And that can be seen to be addressing very specific collective action problems that are similarly faced in that area. And so this is now leading into the research that we're just starting out. So we're putting this together. This is very early stages. So it's well positioned for feedback and comments, but generally we posit that the structure of a science policy interface or the performance can be conceptualized based on its ability to standardize the science and achieve consensus, as well as its ability to prescribe recommendations and guidelines and provide technical support. It's worth noting that there isn't a single science policy interface, to my knowledge, that does the second thing. But to varying degrees, there are science policy interfaces that are able to achieve consensus at pace or slightly behind pace of relevant conference meetings for different treaties. And so the question now is that we're asking is how can we isolate conditions for success and apply these lessons learned to ongoing treaty negotiations for a pandemic instrument, as well as, with the idea that doing so might help address some of the collective action problems that we face in global health. And here, I just wanted to draw some questions as we start off at looking at this. And we have the IPCC for climate change that can monitor global carbon output and carbon in the atmosphere. But a science policy interface for health is a little bit different because we're talking about individual patient data. And so it's not as easy as just monitoring the atmospheric conditions. It involves considerations about people and information about our health. And so there's potentially ethical questions about the collection of data and the purposes of collecting data and the benefits from that data and how those benefits are distributed. So these again are just early conceptions of different ways that or different considerations we'll have to include as we start to make recommendations for what a science policy interface for global health would look like. And a couple of years ago, many of the same collaborators, we came up with a few ideas about what an SPI for AMR would look like. It would have to recognize different ways of knowing, that there could be multiple different kinds of data that would need to be included. And then also, as we try to translate best practices, we have to recognize that there are specific political purposes that are always involved when we think about imagining or instantiating a new future. These are political questions that serve specific interests, and so those need to be equitably determined as well. And then also, there will have to be decisions in terms of what gets measured, where the funding goes, and how evidence is generated, which also raises ethical considerations about the endeavor to create a strong scientific basis on which to base our policy. And so I'll just conclude with this question, and this is really the heart of the research question that we're now asking is how can we craft a science policy interface for global health that simultaneously protects privacy, upholds data justice, is able to perform well, and works for the benefit of all people. So I'll leave it at that. Thank you.
Okay, thank you so much.